Hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy. So, the hypertrophic cardiomyopathy is basically when there is less space for blood to fill in the heart, and because of the genetic mutations, this there is this less filling of the blood in the heart, and which causes the obstruction in the heart, and hence the blood cannot be pumped out efficiently. So the causes for hypertrophic obstructive cardiomyopathy is genetic mutation in TNR gene and Friedreich's ataxia. So this genetic mutation will cause in the decrease in sarcomere functioning, and which will lead to the stimulation of growth factors, which will result in growth of more of the heart cells in the concentric fashion. And here we can see the heart will get thickened because of the concentric growth of the muscle. So basically it can be seen in the athletes, and if there's any family history of sudden cardiac death. What are the signs and symptoms we can see with the patients with HCM? So these are syncope with exertion, and angina on exertion, that is chest pain on exertion. Talking about pathology, we can see a left ventricular hypertrophy, left atrial enlargement, left atrial hypertrophy, congestive heart failure, decrease in heart sounds, S4 sound, and mitral regurgitation murmur because of the dynamic obstruction. Because of as these cells grow, it will cause in the obstruction at the interventricular septum, and just before the aorta, and hence the blood cannot be pumped out efficiently because of this obstruction, and hence the forceful blood will be then pushed into the atrium, and hence we can hear murmur, that is mitral regurgitation murmur. And this murmur can be increased in the voicing during auscultation by squaring and valsalva. Now, how do we diagnose it? So for diagnosis, we can go for echocardiogram always, ECG to look for Q waves in inferior and lateral leads, and we can see other things like a left ventricular hypertrophy, atrial fibrillation, ventricular tachycardia. And for echocardiography, we can see thick interventricular septum. We can see the obstruction, and the ejection fraction will be normal, but there will be increase in the walls, thickness of the walls of the ventricle, and there will be decrease in diameter of the ventricle and increase in atrial diameter, because the blood has a less space in the ventricle, so it will be collected in the atrium, and to hold this more amount of blood coming in, and also from the ventricles to the atrium, the atrium will enlarge. So this is the reason for atrial enlargement, and there will be increase in atrial diameter in the echocardiogram, we can see. And this was about echocardiogram and ECG. And about Q waves, we will look it into this ECG strip. As it's mentioned that pathologic Q waves are seen in inferior lateral leads. So inferior and lateral leads, so we can see it here. in the this here, here, that is lead 2, lead 3, and AVF. So these are the inferior leads. So we can see the Q wave in inferior leads in this ECG strip. And on auscultation, so the murmur will be crescendo decrescendo murmur because of the dynamic obstruction of interventricular septum. And about treatment, we can give beta blockers, diltiazem, which is one of the kind of calcium channel blockers. And what to avoid is to avoid atrial dilators such as ACE inhibitors, ARBs, and also to avoid nitro, and digoxin is also contraindicated. So why to avoid atrial dilators? That is because there will be less filling of the blood, and it's already there is less space for the blood to pump out, and if there will be less blood to be filled in, then it will cause the hypertension. So that is why severe hypertension will be caused, and we will have to increase preload. So to increase preload, we'll have to ask the patient to be in fluid, to have more fluid, and also restrict diuretics. And we can go for surgery if it's too much, with alcohol ablation and myomectomy. Additional part of the heart cells will be cut out. And this was all about the treatment of hypertrophic obstructive cardiomyopathy.